Greetings and welcome. My name is Brad Monk, and I'm a gynecologic oncologist and the director of the GOG Partners Organization and the vice president of the GOG Foundation. I practice here in West Palm Beach, Florida, part of Florida Cancer Specialists. It's my privilege to be with you talking about the idea commitment, community engagement, collaborating to raise awareness, educate, and encourage participation of underrepresented patients in clinical trials. And I'm joined by my friends, Dr. Black. Destin, say hello.
Hi, Dr. Monk. I'm happy to be here.
Tell us about where you practice and what it's like to live in Shreveport.
Well, I am a GYN oncologist in Shreveport, Louisiana. I completed my fellowship in 2007, and Louisiana is home for me. So I came back home after my training. I trained at Memorial Sloan Kettering Cancer Center, and it's great. It's great practicing here. We have a wonderful healthcare community. We are quite underserved for the GYN oncology space. I'm the only GYN oncologist in North Louisiana. So that we certainly have some challenges, but we've definitely been able to overcome that. And I'm excited to talk about some of the things that we've done to help make our community stronger in this space and give us the access to GYN oncology trials.
Well, thank you what you're doing. We're also joined by Dr. Joan Walker. Joan, hi. Tell us what it's like to practice in Oklahoma City.
Good morning. I'm a little different in that I do cancer prevention and control as well as treatment trials. And I'm at the University of Oklahoma Stevenson Cancer Center. We are a NCI designated cancer center and trying to become a comprehensive cancer center. And that means that we have to actually change incidence and mortality for our state. So we call the state of Oklahoma our catchment area, and we are in full swing at trying to really bring down cervix cancer incidence, eliminate cervical cancer, improve screening in colorectal, lung cancer, breast, prostate, and we just were awarded the American Cancer Society Cancer Health Equity Research Center Awards. So we also have the NCI Cancer Screening Research Network, as well as the HPV self-collection study called SHIP, or the last mile. So when I am discussing clinical trials, I will interject that we don't just do treatment trials. I will discuss how we go about doing treatment trials, especially with IND drugs, but also how we do community outreach, engagement, and cancer prevention.
Well, that's great. And I want to thank you personally. Both Dr. Walker and I did our fellowships at the University of California, Irvine. And, I appreciate your mentorship. You finished your fellowship about the same time that I was starting. You've always been good to me, kind to me, mentoring me, and I continue to have a lot to learn, and I'm very grateful for that. So thank you, and I really am grateful for our friendship, and thank you for joining us. So I'm going to give a few introductory slides. We're going to talk about two techniques, and again, it's not one size fits all. So Dr. Walker says, look, we're in the center, almost the center of the state of Oklahoma, and we bring people to us. It's a good model. So we heard from Dr. Black, we're here and we actually try to go to the community, which frankly is my model here in Florida, where I have 30 research sites in the state of Florida where I'm the medical director. So there are other ways to do it as well, but we're going to focus on sort of the bringing the trial to the patient and bringing the patient to the trial. So I'm going to say a few introductory words. I want to start talking about social determinants of health. These are conditions in the environments where people are born, live, learn, work, play, worship, and hopefully age, that affect a wide range of health functioning and quality of life. So this is the perspective sort of that informs what we're trying to do in creating opportunities to improve. we can't really improve the middle. We can't really change, I guess we could, where they live. We certainly can't change their ethnicity or their age. So we try to attack structural inequities, and I just put on here housing. We try to attack here on the right health inequities to try to raise the quality of care. And I'm going to sort of outline the best ways to do that. I'm going to talk a little. Yeah,
Fred,
go ahead. I love it.
I want you to know that we actually do have an attack on social determinants of health. So we have a screening questionnaire the patient gets when they are first seen to elicit what their challenges are. And that screening questionnaire then has to be corrected for the problems that they're facing. And we have a contract with a team of community health workers who live in the community of the patient, who then connects the patient to services. So if they are struggling with housing, if they're struggling with social support, if struggling with food, transportation, we meet that need. And that is the first step before you can actually sign consent, get the chemo going, et cetera, is to try to make sure the patient can get there. The patients who have positive social determinants of health, or PHQ-9, which is a depression screen, have to be attended to for their challenges before they can be compliant in their care. And we attack that with a whole team of social workers and psychologists, psychiatrists, and the community health worker, in order to make sure they don't go to the ER because of their suffering or fail to meet their appointments and their chemo time. You have to get your treatment done on time if you want to have cancer survivors.
Boy, that's great. And thank you for what you're doing. And obviously jump in, that's important. I want to review with you some of the specifics related to the two most common cancers that we treat, ovarian cancer and endometrial cancer. We're not going to talk a lot about cervical cancer, although that's important. And I want to just point out the obvious, although maybe not so obvious to some, that suboptimal treatment for survival in ovarian cancer occurs in older women, Black women, low-income women, women with public health insurance, and ultimately Hispanic and Latina descent. And there are psychological issues, Joan, that you outlined, and there are also funding issues. So this is very important. And I just want to show you the data. And you can see here that in the teal color, if you will, non-Hispanic Blacks, you can see that survival is lower. It's lower, and there's a reason for it. And there is a solution to that opportunity. And Dr. Walker began to describe that. It's lower in all types, serous types, and clear cell types. And we wanted to point that out. And so what are the solutions? The solutions really are twofold. Number one, high volume centers. High volume treatment centers are associated with better outcomes for Black women with ovarian cancer. I think it's pretty clear. This slows it. This shows that the high volume centers, high volume HV and a high volume physician, regardless of race and ethnicity, have the best outcome. I'm going to keep us moving here because there are other opportunities to navigate the healthcare ecosystem, because we have to do better. We have to help them receive surgery, which they're not receiving, people. And it's not just social determinants of all patients. We leave no one behind. Guideline-based treatment, and overcome the barriers, Joan, that you nicely pointed out. And here's the point, and this is why we're here today. That on the left, that if OS says in patients never enrolled in a clinical trial is worse. So you can bridge the gap and overcome the disparity if the patient goes on a clinical trial. We actually have a presentation at ASCO from Outback in cervical cancer that if a Latina or ethnically diverse woman enrolls in Outback, the outcomes are the same regardless of ethnicity. And this is also relevant to endometrial cancer. As you know, endometrial cancer is the most common gynecologic cancer. It now is the most lethal gynecologic cancer. And there are reasons for the disparity in women of color, not just related to social determinants of health, but to biology. Okay, they have tumors here in the lower right-hand corner. They have more aggressive endometrial cancers, particularly of P53 mutated tumors, particularly serous cancers.
Brad, I'd
Go
like
ahead.
to bring up another topic, and
Thanks.
that's why I focus on prevention, is that I
Yes.
lead the African American Community Advisory Board, and I'm the Diversity, Equity, Inclusion Assistant Director for Stevenson Cancer Center, and we have three community advisory boards. One's Hispanic, one's Native American, American Indian, and then I lead the African American Community Advisory Board. And we have a problem in that we are not teaching cancer symptoms to patients.
Right.
African American folks have fibroids very commonly, and they have abnormal uterine bleeding very commonly, and they don't perceive bleeding as a symptom of cancer.
Mm-hmm.
And so they present very late. And it's not just African American women, it's all Oklahomans, I don't know about the rest of the country, are not taught anything about symptoms of cancer. They're also not taught anything about genetics, and they're not taught about family histories. They might have Lynch syndrome and not know it. They might have BRCA1 and not know it. And so I think it's incredibly important that GOG and SGO lead in teaching cancer symptoms, teaching about family history, teaching about genetics, and get our patients the right care earlier so that they don't have stage 3, stage 4, which is the problem that we see over and over again in both endometrial and ovarian cancer, which is not necessary.
I like the term spot the spot to bring to the attention of postmenopausal bleeding. So, and you can see though that we have a lot of work to do. You see on the left that the number of cases are increasing, particularly in women of color, and that the survival rates are worse. So we need to do better. This probably puts it in the easiest terms that if you compare Black versus white, whether it be early stage or later stage tumors, they do worse. And importantly, also there's 2 solutions. Just like in ovarian cancer, the volume of the care and enrolling on a clinical trial. So we need to attack this ecosystem, and I love it. Health awareness, education, prevention, and early diagnosis and treatment, really working through navigators, social support, transportation assistance, and you said it well. I want to focus to the opportunity that you have, and I want to hear from you how you are addressing community-based oncology challenges in various populations in a very rural part of the country in northern Louisiana. Go ahead.
Thanks, Dr. Monk and Dr. Walker. So, as you know, each community is unique, and in North Louisiana, we face some real challenges. What we have here is like 3 healthcare systems that they're strong systems, but because of a lot of politics and competition, there's really no real collaboration in this space. And so what I wanted to do is to leverage the strengths in our community to try to provide clinical trials to our patient population. And so I pretty much, the goal of starting this site management organization was to connect different healthcare systems. So these are sites that are not part of the same healthcare system. And I really took the idea came to me, I took a page out of Jackson, Mississippi's playbook. Many years ago, you may not know this, you probably do though, in the 1970s, Dr. Borno was a GYN oncologist that went to Jackson, and he collaborated with a medical oncologist there, Tate Thigpen. And those 2 became very well respected in the field, but more importantly, they actually addressed a need in Mississippi at the time. And right after I graduated from fellowship, I met with Dr. Thigpen and talked to him about how this happened. And it was quite an interesting story. But that is where I started with this idea of really working with what I have in this community, because it's just me. I'm it in North Louisiana. And so I really started to identify medical oncologists that were strong, well-trained, interested, and it's been quite a success for me to do this approach. I think there's a lot of wonderful oncologists out there that have really keep up with the literature. They really want to be involved. They're very engaged, and they're very interested in offering their patients clinical trials. So that's sort of where this idea started. Since starting, I've opened 22 trials, and I think I would
Wow.
say that I'm quite successful. You know, it's not what you would the amount of success, but part of that is I'm very much involved with the team approach, and I have a great team. I've built a great team. I'm able to actually invest in creating and expanding the team. There's a very short chain of command. I don't have to go through all the politics, you know. It's mainly just getting the contracts in place, making sure that we really leverage the strengths that we have. So the thing is, the first thing I would say is what I did was just basically identifying these sites, you know, and also providing on-site education and coordination. One of the biggest barriers is people just don't know how to do a trial. Even if they want to, they don't have the know-how. So really, like, what I've done is I've paired nurse practitioners. I have great coordinators, and they go in and they teach it, and we work very closely together to make sure that it's a success.
One of the things that's impressive to me is that you get the leverage of a high volume center as a group, right? Each individual may not be a high volume treater, but collectively they are, and that elevates the standard of care. Would that be accurate?
Yes, I would say that's accurate. Let me just show you the map of Louisiana just to kind of put it in perspective. A
Okay.
lot of people think that you see up here on the top, Shreveport, you know, they think, oh, well, why don't patients, you know, you have New Orleans, it's so strong. And New Orleans has a great group of GYN oncologists, but they're 330 miles away. And you know, and I can tell you, so many people think that they're right. Oh, I'll come visit you. I'll be in New Orleans this weekend, and they can't just drive up here, you know. So what really it leaves is really, in order to be successful, you have to work with your community. You have to work with the medical oncologist. I can't do everything, but I can certainly be the leader of the team and to get these trials to patients. So really, the sites that, you know, it's pretty new, this adventure, this endeavor, this, you know, goal.
Oh,
But it's done very well, and really, the sites are in Shreveport and Ruston, Louisiana. Ruston's about a 2-hour drive from here, and that's very helpful for patients. So it gives a little bit more coverage to the east part of the state. And then in the central part is where we're trying to expand a little bit south of here, sort of that Natchitoches, Alexandria area. And so that's really the big picture of kind of what I'm doing in this space. Definitely working with the community. We have a nonprofit organization that helps with gas cards. It's called the Caddo-Bossier Cancer Foundation League. That's been very helpful, and trying to identify potential barriers on the front end. And I think that's important. And I can't say how important that is. Like, even in trial design, allowing for a certain amount of, you know, allowing for, you know, remote consenting and just stuff, you know, simple things like that. Trying, if you can, to have a line item for transportation issues, you know, even if it's a small amount, any bit will help, you know, these patients, especially in our trials like cervical cancer, where we know this is a much more vulnerable patient population. So that really sums up kind of what we're doing up here. And
before I get to Dr. Walker, tell us about the business aspect. How do you hold this network together in different hospital systems in a way that you know, money is changing hands and
yes,
goes? How do you manage the contracts and the egos?
well, yeah. So first I had to go back to school. I went back and got my business degree. I got a master's in health administration. I did that during COVID. And then also I tried to educate myself the best I could. I went through this organization called the ACRP, where they have like a certification program as a PI, which, you know, it's just a certification certificate. That doesn't mean anything, but the educational side of it, there's so many things I didn't know that I didn't know, you know. And then working really closely with the administrators at the hospital. I think
Right.
I was surprised at how supportive they were of this. Many hospitals they want to outsource that, at least in my community. We don't have an NCI designated cancer center. We have a community cancer center. And the truth is 2/3 of people in the US are being treated at a community cancer center. So we
Mhm.
have to think about how can we collaborate with these centers. And there are politics involved, but I found that maybe it's because I've been here for 16 years. The community hospitals know me. They've shared patients with me over the years. Um, Surprisingly, it's been very easy to work with administrators. The CEO of the hospital has been incredibly supportive of in the hospital systems. The main thing is just getting the legal contracts in place, the master agreement,
Right.
facility use agreements, working with a good attorney and it's trained in this space. And then working with the sponsors. They're actually very excited about this type of thing, especially with the FDA wanting more diversity in clinical trials. So
Mhm.
I just wanted to share kind of what I'm doing. Maybe there are other communities that could benefit from learning a little bit about, this model. I will tell you, it remains to be seen for sure if it's going to work. So far, it's working, and I just take it one day at a time, one step at a
Thank you.
time. But it's so far been successful, and I think our history speaks for itself in terms of how we're doing. And well, I'll see after this week really how I'm doing. But
She says this week because she's such a high enroller that the FDA is kicking the tires and looking under the
yeah,
hood in an FDA audit. So
yeah.
would it be okay if individuals that are working on networks reach out to you,
Oh,
Dustin? Would that be
absolutely. I would,
okay?
I'd love to mentor anybody, and I look forward to receiving mentorship from you guys. I mean, both of y'all, I have always had such respect for, and I've been inspired by, and I just am, grateful to actually be able to be sitting at the table, really. So
We're
thank
grateful.
you.
So Joan, you have a little bit different approach. So why don't you go ahead and take it away and talk to us about how you approach this being in an NCI designated comprehensive cancer center, but in equally rural community. I love the map concept. Go ahead.
Yeah, so we have actually both models. We have three big systems within Oklahoma City. We have the Catholic system that's called St. Anthony's. We have Mercy. We have Baptist. And they are enrollers for our clinical trials, but they don't. They have the opportunity, but they are not efficient or we have one GYN oncologist in the community, and she sends us her patients because we trained her. She worked for us for 5 years. So that's the model, sort of like Dustin was describing. But we have taken another approach in that we have set up a Stevenson Cancer Center in the 3 largest cities. So Oklahoma City is our base. Norman, Oklahoma was our first outreach, and that's the campus for the University of Oklahoma is Norman. We have a practice in Norman, medical oncologists, radiation oncologists, and they will do treatment trials if it's chemotherapy related. We have not yet set up a clinical trials pharmacy there. So if there's an IND drug or something, we have to treat them in Oklahoma City. It's only 20 miles, but sometimes it's an hour's drive. It's a bad traffic pipeline. Tulsa, we just announced we have opened the OU Tulsa Stevenson Cancer Center, or not opened, we've broken ground. We will open, I think, in 2026. So Tulsa now enrolls through a private practice group, which has 3 GYN oncologists. Michael Gold, we trained, and we trained one other in Tulsa. And then we have others that have been there longer. But anyway, we have Tulsa and Norman as our actual OU Stevenson Cancer Center sites. We have built an American Cancer Society Hope Lodge on the campus of the OU Health Sciences Center. And that I'm unfortunately a chief fundraiser. So by our fundraising, we have paid for the food and the housing of our patients. So we give them transportation through American Cancer Society or through our own private philanthropy work, so that people who like cervical cancer have to stay for a week at a time. They and their families can stay in the Hope Lodge for their radiation and go back on weekends. We provide the regulatory support, quality support, quality management, education and training of staff for our network. We do have smaller sites in Lawton, which is now the 4th largest city in more of the southwest side of the state. But these stars are private practice sites where we have contracts and can run our trials. But we really are expecting we'll enroll mostly from Oklahoma City, Tulsa, and Norman. The NCI requires a community cancer center, an NCI designated cancer center, as I said, to change mortality and incidence. We are working incredibly hard for that. We have now 4 mobile health screening buses. So we can go out and do mammograms and lung cancer screening, and we can do the HPV self-test and the FIT test. So we are hoping that our rural population will actually get care through this network. And we have partnered with all the federally qualified health centers within the state and with the Indian Health Service and the Tribal Health Service. So all of the tribes have contracted with us, and we have Native American navigators, and those Native American navigators make sure that the patients get their CT scans on time, their labs on time. We are not allowed to do them at our facility. They have to be done at the Tribal Health Center. And so they get that taken care of, get insurance approval for everything. And we are trying to bring that Native American model into other communities as well. Oh, one other thing about our state. So our network of primary care providers is called OK Trust. It's Oklahoma tribal, rural, urban cancer screening treatment trial network. So Oklahoma Trust is our cancer screening research screening network. And so we're really excited about that. We got a NCI grant to bring that program to all of our rural communities. And so we've got 10 sites that are not on this list. I didn't put in the slide for the Oklahoma Trust. Next slide. The other work that we're doing is to provide the patient navigator, which I mentioned. We have the Native American navigation and coordination of care with the Indian Health Service and the tribal health systems. We also have community health workers now. We have social determinants of health screening. And then each of our cancer sites has a nurse navigator. So we have a lung cancer nurse navigator, a GYN cancer nurse navigator, prostate, et cetera. So that those patients get their treatment on time, they get the barriers to their care overcome, and then we have a complete supportive care system with, as I said, psychologists, social workers, et cetera. The American Cancer Society I discussed already, have the Hope Lodge. The transportation can be through the American Cancer Society, who has drivers, or we can give gas cards if patients have family members who can help them. And then we have charity dollars for people. Sometimes they need $50 or something just to get through the day. We have a nutrition, dietitian. We have free food. We have a food bank. So the patients, when they're getting their chemo, they get a good meal. And then we're working on telemedicine. It's becoming more acceptable through the FDA and through NRG and GOG to do more remote consenting, remote treatment, especially oral meds visits by video conferencing. We're allowed to use nurse practitioners and PAs. That's just a brand new approval that we have. And so we are trying, we have a team of nurses who screen all the patients and make sure that everybody who's eligible for a clinical trial is offered a clinical trial. The number one reason people are not on a clinical trial is they were not asked. And so we have no barriers to that. And we actually overrepresent the underrepresented community on our treatment trials. So if we have a 10% Hispanic population, we usually get 15% on our trials. If we have a Native American population of 10%, we usually get 12% on our trial. We overrepresent on our minorities on our trials. I do think that we're going to have a hard time doing any IND drugs in remote unless we have a cancer pharmacy there. The oral drugs are going to make it easier. And yet we have to, give the first dose in the clinic and then make sure they understand the instructions and keep a pill diary, et cetera. But the oral agents are certainly going to be much easier. It seems like I have other topics I wanted to discuss, but go ahead and we can.
Yeah, so I was just going to sort of say, first of all, that, the GOG Foundation has two houses, GOG Partners, and those are pharmaceutical company sponsored trials. We also sponsor within Partners our own trials, such as Rock and Hot, and then Energy, still under the same house, still under the same foundation, to work through CTEP. And I remind you that our mission is to conduct clinical and translational research that impacts patients through prevention, and thank you, Joan, and treatment. But our vision really is to be the premier network to change patients' lives. So I appreciate that. I'm going to ask each of you sort of to summarize with one piece of advice. That if I'm sitting here listening, what can I do in the short term to improve diversity in clinical trial enrollment, whether it be in GOG Partners or Energy? So Destin, what would your one piece of advice be? And then Joan, I'll give you the last word.
I think that perhaps one of the most important steps is to make a plan for your patients, for your diverse patient population early on, and trial development as early as that.
Mm-hmm. Yeah, you got to have a plan. As this very famous baseball player said, his name is Yogi Berra. He was a catcher for the Yankees. He says, if you don't know where you're going, you might end up somewhere else. So you have to have a plan to know where you're going. Joan, what would be your one piece of advice in helping us do
I like
better?
the going where the puck is going to be.
Love it.
Yeah, the hockey term. You don't go where the puck is, you go where the puck's going to be. I think it's incredibly important that the patients see people that look like them.
Trust.
That's the number one thing, is you have to develop a trust. You have to hire your support staff who look like the patient if you don't. We have an African-American GYN oncologist. We have a Hispanic breast surgeon. We have been working hard to bring the faces of the patients into our clinics as the providers. We have nurse practitioners from every background. We have a Langston University, an African-American college in our town. And so we have a nursing school in Langston University that puts out excellent nurses. And so we hire them, and that brings our diversity numbers up. You have our clinical trials office with all of our consenting nurses looking like our patient population. So that incredibly helps. We have a huge phase 1 program, and our patients learn to like us and learn to trust us when they first get their diagnosis and their surgery, et cetera. We are a very high volume institution. We're in the top 10 most of the time, but number 1 in many things. And in phase 1, I think we're the 10th in the country. And that program is going amazingly well. And that is where you can actually bring the brand new drugs to the patient who is failing standard of care therapy. And I hope that that will change outcomes on the back end. I'd prefer to change outcomes on the front end and prevent the cancer, screen for the cancer, teach people about symptoms and teach people about genetics, get everybody genetic testing. I'm working on that. I'm trying to work with Myriad to change policy, but getting people a drug that actually is targeted towards their particular tumor characteristics early on in their care through a phase 1 program is, I think, going to be the answer. So thank you, Brad. Thank you for hosting
Thank you.
This beautiful, wonderful discussion.
Well, thank you, Dr. Walker, and thank you, Dr. Black, for what you're doing. I also want to thank the GOG team. This would not be possible without Jen Klein and Lindsay Muller. Thank you. I want to thank the DMP production team. So for more information on the GOG's Idea Commitment Initiative, please visit our website. You see gog.org/idea-commitment, and join us in making a difference. So thank you so much today. Good seeing everyone, and thank you for joining us. So long for now.